Good morning. Mark Wakefield from Urology. I was going to base my talk on a few case examples and try to keep it informal and straightforward, which is sometimes difficult to do when you converge neurologic causes of urinary symptoms. Next slide. So I want to give a little bit of information about what normal urination is like and how it manages and what we expect from that. And then the challenge for urologists is that aging occurs in parallel with onset of Parkinson's. And so we sometimes have trouble sorting out what is the normal associated urinary symptoms of aging, which become more prevalent and severe in many patients, versus those that we would attribute to Parkinson's disease, and how we might treat those differently. And to help kind of classify those urinary symptoms into different buckets can make it easier for us to communicate about it, keep our differential diagnosis broad, and help us come up with a proper treatment strategy. So I came up with what I perceive to be the 5 most common examples. Men with what we would attribute to the prostate urinary symptoms and their treatment. The inability to urinate, which in men especially is a progression of those prostate-related symptoms, but not exclusively so. One of the most troubling, we heard a little bit about treatment based on bother of hallucinations, but one of the most common troubling and bothersome symptoms to patients with urinary symptoms with or without Parkinson's is nocturia, meaning getting up at night to urinate, which is disruptive of a good night's sleep. And if you have Parkinson's, I just relearned that there's a lot of impact on your sleep, and so let's add this to that. Most commonly, and it's indifferent to gender, although the etiology or the cause might be different, is what we generically term overactive bladder, which is frequency of urination, urgency of urination, and potentially leakage of urine with urgency during the day. And then finally, stress urinary incontinence, which usually is in women and is often blamed on previous childbirth, but can occur in patients with Parkinson's and should have a little bit of special attention at the end of this discussion. So overlapping urinary symptoms that we'll associate with aging and Parkinson's disease and some treatment options. So most of us, when we're young and healthy, don't think about our urinary symptoms, and it just happens and it's awesome. But it turns out to be pretty complex. But I'm just a simple country urologist, so I'm going to break it down. The bladder has 2 functions. It's going to store urine. It's going to fill at a low pressure. And then when we want to, we're going to urinate in a socially acceptable circumstance and empty to completion. All right? And that requires the bladder to relax, our brain to inhibit the desire to go to the bathroom until we want to, and then when we're able to, for the sphincter to relax and the urine to flow out to completion. All right, next slide. And no surprise in a neurology conversation, it's a little bit more complicated than that. And you know, you can think about as we get to potty training as a child, the brain learns to inhibit the natural contractions of the bladder. And for many reasons and many diseases, many of them neurologic beyond Parkinson's disease, that changes. And so all the things that we learned about Parkinson's have an impact potentially on one of these layers from the head to the toe, so to speak, of the neurologic system and urinary function. Next slide. So independent of Parkinson's disease, men generally develop enlargement of the prostate, and whether that impacts urination is not inevitable, but it's relatively common. It fills our clinics with patients, and we have a lot of treatment options. As I alluded to earlier, women after childbirth may develop pelvic organ prolapse, associated stress urinary incontinence, also more common as we age. Overactive bladder, more common as we age. And then a little bit more subtle is the changes in the way that we concentrate our urine, especially at night, which can impact the frequency of urination at night. So it's a very prevalent problem. I tried to find some tasteful art related to urology, not so easy. But for those of you who have not been in the typical male football stadium restroom, this would be a good one, right? No privacy. I always thought this would be an excellent place to market urology, but we have plenty of patients. Marketing's not our need right now. So as we age, these urinary symptoms, which we generically call lower urinary tract symptoms or LUTs, increase in frequency and severity. We can assess the severity by symptom scores. These are validated in males with enlarged prostate. They're not diagnostic, but they do help us objectively measure the response to our therapy and gauge the severity. One of the most important things is someone may have a very high score but low bother, and then we're not compelled to aggressively treat. There are some circumstances where the consequences of urinary dysfunction are serious medical problems, like the inability to urinate or severe infection. But many times this is a quality of life problem, and we'll manage it in concert with other condition management. That changes a little bit when you get to inability to urinate at all. That starts to become more pressing. Okay, so our first case is a man with increasing frequency of urination. Often the first symptom is decreased force of stream or slower urinary passage, but most of men as we age, we don't get bothered by that very much. We might be at that stack of urinals at the football game and notice it takes us a little longer than the 25-year-old next to us, but so what, right? The game's not that close, and the lines were long anyway. But as we get more frequency of urination, that's more disruptive and more likely to lead a patient to be evaluated. And if that affects us at night, that becomes even more problematic. So what do we do about that? Many patients self-medicate. There's a lot of supplements available, over-the-counter health food stores, and some of them are effective. We don't know a lot about their side effects. We definitely don't know anything about their interaction with Parkinson's medications. So I think it's better to start with the standard prescription medications in this scenario. 5-alpha reductase inhibitors slowly shrink the prostate, and they don't have many side effects related to Parkinson's, so that's an important treatment option for us. They tend to be more slow in recovery of urinary symptoms or improvement in urinary symptoms, so we have to manage expectations. Tadalafil, which is the generic Cialis, is improved by the FDA for the treatment of urinary symptoms related to an enlarged prostate. Has the extra benefit of improving sexual function, which we saw is a common problem among patients with Parkinson's. The bladder antispasmodics, traditionally antimuscarinics, such as oxybutynin, can be very helpful for the urinary frequency and urgency, but they have a lot of side effects and are generally frowned upon on an aging patient population. I've had a few people use them because they kind of cut down on the salivary. One of the side effects is dry mouth, so excessive salivation, a side effect of medication being used for the benefit of the patient. And then beta-3 agonists, which facilitate bladder relaxation, and mirabegron is also associated with increased blood pressure. So sometimes that can be a useful adjunct to patients with orthostatic hypotension. But the mainstay is the top of the list, the alpha blockers. Tamsulosin is the most commonly prescribed, and it has the great trade name of Flomax, like brilliant. Helps facilitate urinary flow by relaxing the smooth muscle in the prostate. Silodosin is probably the safest in patients with Parkinson's disease. It's also got a great trade name, Rapaflow. It has less orthostatic hypotension, and that's the limiting factor of these medications, which are generally effective for BPH in men. Next slide. Sometimes the BPH can progress to these medical significant complications where we're going to want to intervene more aggressively. But you can see this is a very common problem, urinary symptoms, inability to urinate, and our second patient is usually due to BPH, but neurologic disorders make up a high percentage of patients overall. Next slide. And the treatment or the diagnosis can be done non-invasively. This is a CT scan. That's a little overkill for diagnosing urinary retention, but we do have bedside ultrasound scanners that can help us determine how much urine is being left behind, how much is too much, not being able to urinate at all, a cup, a quart. Not my personal record, but my patient's personal record is 4 liters, so almost a gallon of urine in their bladder. Next slide. So the standard treatment for most patients is a TURP, transurethral resection of the prostate, and we have a lot of minimally invasive treatments that try to improve the mousetrap, but none of them are as good as the gold standard transurethral resection of the prostate. Sometimes affectionately called, but not very good marketing, the Roto-Rooter. Next slide. Which is depicted here. The view from the eye of the surgeon is through a scope looking at the prostate, which is blocking the urinary channel. We use a little electrical loop, and that's what it looks like. And we whittle out the obstructed channel from the inside and create a passageway for urine to flow through. But like any surgery, there's the potential complication of bleeding, which can be controlled with electrocautery, but it takes some time for that to heal. So people have been working on alternative methods. This is Urolift, is a trade name. It kind of springs open the prostate without removing any tissue. It would be very appealing for a patient with Parkinson's disease because no surgery is reversible, but the impact of this surgery on someone and their recovery is less invasive. So we have our reasons that we do this: inability to urinate, bladder stones, infections. But one of the most concerning side effects is incontinence. And if you open up the urology textbook, there's lines like, don't ever do a TURP on a patient with Parkinson's disease because they'll end up with incontinence. And there's been some debate about whether that's true or not. But if you can't pee, really the discussion is it better to try to help you urinate and risk incontinence, or live with a catheter for drainage or intermittent catheterization? So that's a very individualized discussion because the risks are real. But we shouldn't be trapped by our dogma that this is inevitably going to lead to incontinence. So if you're fit enough for surgery, we should not exclude TURP as a possibility for a man with urinary retention from BPH. Next slide. Okay, case number 3, nocturia. This could be a man or a woman, increasing frequency of urination at night. What's normal? 0, 1, maybe 2 times a night getting up if it doesn't bother your restfulness. But think about mobility challenges being aggravated by nocturia. I had a patient recently tell me that his journey from the bed to the bathroom was a 15 to 20 minute ordeal, often associated with leakage of urine by the time he got to his destination. Now, this is where I think a home occupational therapy assessment might be beneficial. Could you get a bedside commode? The medications might help, but look at the global picture, which is not easy for specialists sometimes to do. So there's multiple causes. Fluid imbalance. So this is a subtle thing. It's not a mechanical thing, so urologists sometimes don't think of this straight away, but nocturnal polyuria is too much urine at night. And it can be due to too much fluid in the day. Dry mouth, think about that. You add fluids to it. The new treatments of diabetes often facilitate glucose in the urine. They're amazing drugs, but they pull water with them, and you go to the bathroom more frequently. Heart failure, take a diuretic, more urine, more peeing. Obstructive sleep apnea, very prevalent, can be a contributor to polyuria at nighttime. Idiopathic overactive bladder can have a neurologic cause from Parkinson's disease. And prostate, we heard earlier that constipation is very common. It can put pressure on the bladder. That's a very mechanical and simplistic view of it, decreasing the storage capacity and can contribute to frequency of urination. And the tool that we like to use is keeping a log of how much urine volume and the times that you urinate to help decide, is this an abnormal shift of urine production in the day to nighttime? And occasionally we'll treat that like you're an adolescent bedwetter and use desmopressin or DDAVP. It takes a careful following to do that, but it's a new thing that we've been trying to help people with frequency of nighttime urination. All right. We can try all the same medications, behavioral therapy, and neuromodulation, and my favorite, relying on the Botox. Injecting the bladder with Botox can really help urinary frequency and urgency. I already mentioned that we're worried about the safety of some of these medications, so the beta-3 agonists have taken over the space in the overactive bladder setting. Okay, final case is stress incontinence. Surgery in Parkinson's patients is always a worry. But if you have stress incontinence, the main side effect of the surgery is not being able to urinate. But we have some minimally invasive techniques. I would say you should be evaluated to make sure whether you're a candidate for surgical treatment of stress incontinence, and Parkinson's shouldn't keep you from having that if you're otherwise fit for surgery. So I'm going to wrap up with more than half of patients with Parkinson's have some voiding symptoms. Some of those may be attributed to conditions other than Parkinson's disease. And during the journey of Parkinson's, you're more likely to develop urinary symptoms as time goes on. They may be due to coincidental medical problems or may be due to Parkinson's disease. And the most common is the frequency and urgency of urination attributed to an overactive bladder. And usually, fortunately, patients are able to empty. We may do special tests to ascertain the etiology, including urodynamics, which is an invasive test. And then I'll conclude with my summary on the treatments. So one, maximize the treatments of Parkinson's disease. Adapt behavior and environment, and cautious surgical interventions. With one caveat, I think deep brain stimulation is a very interesting topic in this area with some dramatic improvements in urinary symptoms witnessed in some patients. So as the team that Dr. Barron mentioned gets put together, we should think about how this impacts urinary symptoms, but it has shown promise in alleviating those overactive bladder symptoms of Parkinson's. With that, I'll conclude. And I have a patient that needs to go to the surgery, but I hope to come back and see you for questions and answer around noon. So, thank you.